Right. Well, we're about a minute or two in here, and we know some more folks will hopefully be coming in as we go. But just want to welcome you. Thank you so much for joining us this afternoon, this morning, as Nick points out, whatever time zone you're in, we're very happy that you're in this webinar with us. My name is Laura Westercamp. I'm a strategy partner at Accenture, their life sciences practice. And gosh, I'm just so delighted to be here today with Drew and Nick to talk about the best practices, the insights, what we need to be thinking about as we really transition to a more hybrid and personalized care model. So just as we get started here, we really encourage conversation as evidenced by where y'all are from in the chat. So please feel free to drop any questions that you have as we go. We'll certainly try to address them as we have this conversation, but certainly at the end, the last 10 or 15 minutes, we'll leave some space for some additional dialogue with Nick and Drew here. So personally, I love personalized health. I think it's so critical. I mean, we see across the patch, CVS has shared their Care Insights survey with 1,000 consumers, and they really found that 85% are looking for more personalized healthcare. And of that, about 80% want their care team to know their personalized goals and what it means for their personal health. So personalized health is here to stay. I'm so honored to be with Drew and Nick, who are going to talk a little bit more about that, and we'll spend the next few minutes digging into that topic. So let me first ask you, Drew. I'd love to hear more about your background, and maybe you could talk a little bit about to your introduction, how have your client conversations changed today from really where they were about 18 months ago before generative AI became this massive monolith that is so present today. So Drew, if you could just introduce yourself first, I'd love it, and maybe address that question too.
Yeah, absolutely. Yeah, thank you. I'm Drew Schiller. I'm the co-founder and CEO at Validic. I'm also the former chair of the health division for the Consumer Technology Association, which puts on CES every year in Las Vegas, which has an amazing digital health presence, and would highly recommend everyone to check that out. I'm also on the executive board of CTA, and I'm on the Highmark Health Technology Advisory Group, among other industry roles. So really happy to be here today and look forward to chatting with you all. My conversations have evolved a lot over the last 18 months with clients around Gen AI, and it was initially similar to conversations we had with blockchain like 5 or 6 years ago, where you could kind of replace Gen AI with the word magic, and that was and it would mean the same thing. Like, there was not initially a lot of understanding, but it was like, hey, what if we used AI with that? But it's really evolved in a pretty productive way, to the extent where I feel like folks are now really understanding where Gen AI can play a role, and specifically how it can help with personalizing some communication for patients. It can help providers better understand a quick summary of some information. And it can certainly help healthcare providers on the back end streamline some of their rote processes that are typically more administrative in nature. So I think that we've seen a big evolution there. We're still, in the probably the first at bat of the first inning in AI. But there's been really, really exciting conversations happening, certainly this year more than last year, around the practical applications and real opportunities that we're seeing.
Yeah, thanks, Drew. Nick, how about you? Tell us a little bit about yourself and what's your perspective on how the conversation around Gen AI has changed?
Yeah, so Nick Wilson, as we were commenting at the beginning, out of our Boston area. So I'm the general manager for Philips Virtual Care business. So really, we partner closely with Drew and large health systems and payers to help support patients with chronic conditions or insurance members, right, who we want to prevent from becoming patients altogether if we can. I think even the last 18 months, but even the last 6 months, something that we've seen together and my team and Drew's team are out having lots of conversations together with especially large IDNs. Is this concept, and Drew just touched on it, of efficiency, but efficiency to a pointed challenge that our system is facing, which is fundamentally we have too many patients and not enough beds and not enough doctors. And what we're seeing now is a lot of conversations around how can I be more efficient? AI is one of the tools in the toolkit that are being talked about, right? To all the things that Drew talked about. But fundamentally, if I'm not going to operate on a patient, how do I keep them in their home, right? And how do I deliver that care at a standard as though they're in my hospital, but fundamentally my hospital just doesn't have enough capacity. So I need to be way more efficient. And one of the efficiencies is how can I use AI, remote monitoring, connected devices, telehealth, kind of all that constellation of new modalities that pre-pandemic maybe didn't exist, but even now in the last 6 months have become really not how do I do a video visit, but how do I put those things together to be uber efficient in delivering care to patients who can stay at home. So, it's really an explosion of conversations. Even 12 months ago, there weren't these many conversations happening. Now there's a new one every week.
Yeah, Nick, I think what you're saying here, just around connecting and coordinating care, and really Gen AI can become not just a tool, but really the lifeblood of how you can start to think about connecting these pieces together. If I can summarize too and just add, from a lot of what I've seen, it's clients who are really making tangible and durable investments in Gen AI, and they're thinking about it that step up from intelligent automation to really how do we take it to the next level? And it's not just back office anymore, but and Drew, I love the point around efficiency, but it's pushing forward to think about, okay, well, what does this mean for my patient and what does this mean for my provider? I was out at Vive in LA, gosh, a couple months ago now, and I spoke to a chief security officer at a med tech company. And this individual said, Laura, the thing I'm most concerned about is it's not if I use Gen AI, it's will patients and providers hold us liable in the future for not using Gen AI because we're being irresponsible with the potential of the technology. On that note, I think it's just so compelling to really think about, especially with this lens of Gen AI, how patient expectations for personalized healthcare are evolving, and what some of the key factors are for this evolution. Gen AI might be one of them. So Drew, if I point it back to you for a second, would love to kind of get your perspective on that big, hairy topic.
Yeah, absolutely. Yeah, thank you so much. And I love this question. I've thought a lot about it, and really, if you think about it, we really live in an era of personalization where we as consumers are having personalized content delivered to us in every way, right? And it's really evolved. So, in the 90s, we had this top-down brand marketing, and then in the 2000s, there was this revolution of search engine discovery, where now we could all of a sudden find things out on our own, which led to this big data analytics. So then in the 2010s, we now had more targeted top-down brand marketing with the big data, but it was still, if you really think about it, top-down. But now today, in our apps, we really have personalized experiences. So, Netflix recommending the next movie for you to watch based on others you've watched, even Netflix developing content based on the way people are watching. Or your order at Starbucks is ready based on a click of a button when you walk in. And McKinsey actually did a study on this and showed that 71% of consumers expect companies to deliver personal interactions, and 76% of us get frustrated when this doesn't happen. And what's interesting about that is that 76% of patients are actually frustrated when they're leaving their medical appointments. And they're frustrated because they're not receiving personal interactions. They're confused. They're feeling confused about their health. They don't feel like they're getting their questions answered. They feel like they need to go and do more research online. And, health systems are in a really competitive environment where, today consumers have far more choice in healthcare than they have before. And as we know, when consumers don't like the experience they receive, it's easier than ever for them to go and choose a different service. And in fact, there was a Harris poll that showed that 69% of patients would switch providers for better services. So this personalization is not just something that we expect in healthcare, it's something we expect everywhere. And the key for healthcare providers is that they need to have the right data to personalize their interactions with patients in order to know what's going on. And so, there's information that we capture every day in our daily lives from, wearables, from in-home health devices, that help to contextualize what is happening so that healthcare providers can know what's going on rather than treating every single patient the same and asking every single survey question that they have. They can actually already have a lot of the information at their fingertips in their clinical workflow to know what the conversation is going to be about, and what they need to address with the patient. And we can get more into it, but with our clients who do this, what we see is that it makes the healthcare providers more effective and efficient with their time. The patients love the interactions that they're able to have because it's more personalized, and it leads to just a better overall experience and outcome.
Yeah, Drew, I love how you walked us through the evolution and what's changed over time and some of the considerations for patients as we think about what does personalization really mean. I'll just add really quickly, about a year ago, we at Accenture conducted a survey of 800 digital natives. And what we really wanted to understand is who's actually using digital health and connected care, and why are they using it? And are they sharing their data? And really the punchline is, of these digital natives, 94% are using a digital health tool to manage their health on a regular basis. And by that, I mean more than 2 to 3 times per week. And they believe they're sharing their data, and they'd like to share their data if it can help them live a healthier life. And Nick, I know that really resonates with you and the type of work that you do. So I'd love to kind of get your perspective on this too, and what's really evolving in personal healthcare, and what are some of those key factors in your opinion?
It's an interesting one, right? Because I feel like we have the digital natives, but we also have a drastic digital divide, right? Particularly in this country.
Right.
And we service a lot of Medicaid members, right? Particularly rural Medicaid members. And what's really interesting is how do you reach those people, right? And where we've really seen kind of the personalization, it's all the stuff that Drew talked about, and a consideration of kind of, we talk, the buzzword of social determinants of health, and right, but fundamentally boil all that down is it affordable, and does it put a burden on me as a person, right? Because if it's not affordable, it doesn't matter, everything else doesn't matter, right? If it puts a burden on me and I have to make the choice between going to a doctor's office or keeping my job, right? Well, and I got to feed my kids, the choice becomes obvious, right? So what we've also seen is the personalization needs to scale up to the digital natives who have these expectations, right, of very sophisticated interaction patterns with the healthcare system or with the tools they're being asked to use, but also scale down to very basic blocking and tackling, as in, hey, I work third shift. Please don't call me for a coaching call about my diabetes at 8 in the morning when I've just gotten home and trying to go to bed, right? So I think we have to, as like a healthcare community, we also have to remember fundamentally, if you look at where do the costs come from, we're designing a lot of the solutions we design are for the healthiest, 10% of the population who are typically wealthy, white, living in an urban kind of, or an ex-urban center, right? Chicago, New York, Boston, San Francisco. There's a huge portion of the population who are over 65, living in, a rural community, who don't have access to a primary care physician, who frankly probably need the solutions more. And we have to remember, as we kind of personalize these healthcare experiences, how that personalization can span that experience beyond personalizing directly into the content. And I think we've seen, even in we tend to assume these are places like Appalachia. Actually, in Chicago, right, where you're from, Laura, something like 25% of children don't have access to Wi-Fi or broadband.
Yeah.
So it's not just in these rural centers. There's also a digital divide in our urban centers that cause challenges, problems, and ultimately cost for the entire healthcare system.
Yeah, Nick, gosh, I think the point you make around you've got to scale down to make sure that you're blocking and tackling the real challenges that patients are facing really resonates with me. And this prompts a thought around, there's almost this tension of care delivery models today. In the traditional model, you go in, you go get your doctor's appointment, you're in person, like maybe you get a text message push or email to look at your My Chart. But would love to get your perspective, Nick, of how these hybrid or fully virtual models, which I've seen those too, of telehealth. I recently experienced one. I was traveling to India and I needed to get malaria medication. I did it fully virtually. But how does this hybrid traditional care model, virtual model, impact personalized experiences? And in your opinion, what do you really need to create to get those personalized experiences right across these different models, which are emerging and frankly, I'd argue have emerged. They're here to stay. Telehealth is here to stay.
Yeah, no, I think it's interesting, right? We're definitely seeing a range of customers have a range of responses, but we're also seeing some pretty consistent themes and frustrations as well, right? So the responses tend to be, I'm a physical environment, right? Your traditional healthcare system, your traditional primary care practice. I'm going to set up a standalone virtual option, right? So CVS, for instance, has their virtual minute clinic option, right? You can go on, you basically get a WebEx. I've used it a bunch myself. It's very convenient, right?
Yep.
You see a lot of big health systems setting those up as well, right? You can set up an urgent care telehealth appointment. We're working with, and Drew's and my team are collectively, we're working with a couple of customers who I think are going to the next generation, which is they're going to this concept of a standard of care, kind of almost site agnostic, right? So they're kind of coming in and saying, hey, if I'm putting a patient in my bed in my facility, or I'm putting a patient in their home bed, how do I make sure that I have a standard that is consistent and I can react and deliver the right care to that patient, regardless of the bed they're in? That's kind of I think a penny dropping to almost say, look, I'm going to virtualize my care, but create standardized care. So whatever I'm delivering, it can be kind of agnostic to the butt in the bed or the butt at home, right? And I think that's a really interesting start of a new care model design. And it's just a start, right? To Drew's analogy, it's kind of the first bat of the first inning. But the fact that we're now talking about it not as virtual versus physical, but as a standard of care, agnostic to the site of care, I think is going to be a real step up, right? Because too often we've relegated kind of virtual care to the simple things, and it's a standalone and it's separate from the rest of the interactions you're having with the healthcare system, right?
Nick, that is such a simple concept to think about, the standard of care agnostic to which model the care is being delivered in. So simple, but so new, I think, from my interactions across the healthcare batch. I just want to add really quickly, and Drew, I want to get your thoughts on this too. There's a question in the chat around how much do health systems really think about third-party self-management tools to bridge that gap when the patient is at home? And I'm curious, I know we're talking about models, but any reaction to kind of that prompt?
Yeah, absolutely. Yeah, I think I can help. Maybe I can continue on this question and also fold in a response to that. So the short answer is that third-party apps and devices for health really do make a difference. But the best experience for consumers is when that is also a part of the care plan that includes their healthcare providers. And so, as an example, there's a patient who has gone through our programs. His name is Steve. I have permission to share his story. And he lives in California. And for over a decade, he had uncontrolled type 2 diabetes, and it's genetic. He developed it when he turned 40, the same way that his brother and his mother and his grandmother had done, right? And so he was really struggling with this condition to the point where he actually had to quit his full-time job because he was just too tired and too sick, and he just didn't have the energy for it. And Steve was trying to be a really good patient, so he would go into his doctor's office, on a quarterly basis, and take his A1C, which was over 9.5, and his doctor would say, "Hey, listen, I don't know what to tell you, Steve. You need to eat healthier and exercise, and walk more." And Steve's like, "I'm trying, doc. Like, I don't know what more to do. I'm taking my metformin. I'm trying to get good sleep. I'm trying to do all these things." So he was also trying to use a third-party glucose monitor to track his glucose, to try to get some understanding there. And he would show the readings. He'd print out his readings and show them to the doctor, right? And he's like, "Help me understand what to do." And the doctor's like, "I don't know what to tell you, but what I do know is your A1C is too high. So like, you got to change something." And Steve felt very alone, and like he was trying to do the right thing. So he actually left that position and went to a different health system that happened to be using Validic to bring data from personal health devices and bring it into the EHR clinical workflow. So Steve's first appointment, the first thing he did, he downloaded an app, connected the glucose meter. And he said, at the beginning, like at the outset, I felt like, oh, I'm engaged. Like this place, like they're at least going to have my data, right? Like it's a whole new thing for him. He was excited. The next appointment, Steve showed up, and because the data was in the clinical workflow, the nurse was able to see the information. And before Steve even saw the doctor, she said, "Hey, listen, Steve, I see you're tracking regularly really well with your glucose. What's going on between 7 and 9 at night? Because your levels are higher then than they are at other times in the day. Let's talk about your behavior." And he's like, "Oh, I'm not doing anything. After dinner, watching Netflix with my wife and kids, we're just kind of hanging out." She's like, "Well, are you eating anything?" He's like, No. I mean, I have a little snack." "Well, what is it?" "It's popcorn." "Oh, well, no, don't worry. It's fat-free, butter-free, like no calorie popcorn." And she's like, "I don't know if that's good for you, Steve. Like, you might try cutting that out and see what happens." So he thought, when the doctor was saying eat healthy, like he thought he was, right? It's 0 calories right on the bag. So he cut that out. Within 30 days, his A1C drops by 0.5 point. And it was the first time he had ever seen a behavior change modification that led to a meaningful improvement in his health. And that led to an ongoing discussion with his clinical team, who had the data, where every time he'd come in, he'd be like, "All right, I've been looking at my numbers, I've been understanding more about my health. And, here's what I'm like, help me understand what's going on at this time of day, or help me understand what I can do to do this." And so over the course of a few years, Steve lost 50 pounds. His A1C is now below 6. He's organic gardening. He's exercising daily. He's back to working a job. I mean, it's completely transformed his life. And he credits the data for being able to have a better, more personalized interaction with his clinical team. And his clinical team was already seeing him. They were already going to see him. They were already going to talk to him. It was just now they could have a conversation with better information. And so that's a way really where, the work that Steve did in the real world on a daily basis really made a difference in creating that hybrid model with third-party devices.
Yeah, Drew, that really strikes a chord. Actually seeing the impact of a change that you're making and being able to track it is so meaningful, because you're then empowered and it's truly personalized health. And I think you've hit on this view of how do we go from this in-person traditional care model, which Steve was experiencing, to something that was hybrid, that integrated the way that he was living into the way that he feels and the way that his healthcare is actually delivered back to him. I feel a little corny saying this, but I got a little chill there when you talked about it, because I'm like, oh my gosh, this is what you want to see. This is why we're in this business. It's not a business, it's a way to help people really change and do the right things to live healthier lives. So Nick, just building off of everything that Drew shared there, I would love to kind of get your perspective on, if I think about breaking this down, what are some of those components that you need to really deploy this hybrid care delivery model that Drew just talked about?
Yeah, I think there's kind of a couple of really key things to consider here, right? And actually, I think one of our attendees actually asked a question around kind of a platform, right? In workflows. I think first and foremost, you have to consider the fact if this is a clinically oriented program, right? And I differentiate that versus a payer-driven program that's more of a wellness space. So if we just put that to the side for the moment. In the clinical world, if it's not working inside of the clinical workflows that the clinicians are already in every day, you're dead in the water, first and foremost, right? Every other component doesn't matter because these guys are already, we all hear about staffing and overwork and, you know, clinicians and especially nurses leaving the profession across all sorts of specialties, right? Not just primary care. Being inside of the workflow is absolutely critical. I think the second element is, and Drew just touched on it, how do you get the data? And how do you get it from off the patient who is not in a controlled clinical environment, right? There's not a nurse walking around every 6 hours taking their blood pressure. You have to get them to do that. So that has to be as simple and as seamless as possible. Ideally, it's got to be within the patient's workflow, right? What are they doing on a day-to-day and how can you get them to do that? And maybe that means you're not getting the best clinical data, but you're getting data, right? So you might have to sacrifice fidelity and accuracy for frequency.
Yeah.
And that's a trade-off, right? That you have to work with the clinical teams on, right? Because it's all well and good if you can get you can get an A-line blood pressure in the hospital. You can get a spot check blood pressure that's administered by a nurse in the hospital. Maybe you're getting a Withings blood pressure, right? And Withings are great devices, but maybe the patient isn't quite putting it accurately, but you're getting some form of data with a trend line over multiple days or multiple points a day, right? I think the last element, and this goes back to staffing. So it's in the workflow. You're getting data. Brilliant. How are you making that data actionable? And do you have a care model and a care team design that lets you interact with the patient, right? Because the story Drew just told, you don't get a successful conclusion unless you have someone interacting with that data and with that patient.
Yeah.
So setting up the team model is super critical. And that can be there's all sorts of variations on that theme, right? We see some clients, they set up a virtual ward essentially, right? They have a charge nurse, they're looking at that data. Those patients are virtually managed with virtual rounds, just like you would have in the hospital, right? So it's kind of a mimicry of what happens. Others we see outsourcing, right? They send that to a nurse call center or a monitoring center to look at that data as a first point of triage, maybe a first point of coaching. Hey, we noticed your A1C popped or your blood glucose popped. What were you doing last night, right? That kind of non-clinical, non-prescription activity.
Yeah.
You get it back to the endocrinologist for the next appointment, right? Here's the things you need to follow up on. There's a bunch of ways to do it, but if you don't have clear workflows that are efficient for the clinical teams, if you don't have a way to collect data and you haven't aligned on what the right data to collect is and what the sacrifices are, there will be trade-offs.
Yeah.
You don't have someone interacting with that data and going back to the patient in a very timely manner to correct the behavior that might be sending issues, you won't be successful. You need all three to be working in concert, right? And if you just focus on one of those at a time, you're going to face headwinds in driving adoption in the clinical community, but also in the patient community.
Yeah, Nick, what I love that you highlighted there is that it's not just about the tools. You can have the best tools in the world, right? You can have the best data analysis. You can connect everything and connect it. Well, we can argue about that, but you can, right? But it's about the ways of working and your ways of working together, and that you built really a care model and care team design, as you spoke about, that enables you to use those tools in an effective way to better deliver care to people at the end of the day. Just, Drew, now that Nick has broken down for us, what are some of those components and considerations, and we've talked about how important the ways of working are, what's your perspective on the obstacles that organizations face when they're transitioning to a hybrid, more personalized care model. And what can they do to overcome some of these challenges?
Yeah, absolutely. Well, building a lot on what Nick said, because I think, Nick, you did a great job outlining the fact of the matter is this is not a technology challenge. We have technology, we collectively in the industry have had technology to implement these programs for a while. It's really an operational challenge to help transition how care is delivered inside an organization. And what we found is that our most successful clients are the ones that that start and iterate, but they always have the end in mind. But oftentimes, what we see with programs is they start, but they're really running a pilot for a very defined period of time, and then they feel like, okay, well, after that, we'll pause and we'll evaluate, and then we'll see. But rather than starting and saying, okay, we're going to start this and we're going to evaluate this after 6 months, but our goal is eventually to get here. So as we build and iterate, we're not stopping the program after a period of time. We're going through this and we're going to continue to build and iterate and continue to find success. And as an example of this, our client Kaiser Permanente has the largest program like this, remote care program in the country, where Validic is bringing data from personal health devices into the Epic clinical workflow across 7 regions of Kaiser. It's about 20 Epic instances. And they've had over 400,000 patients enrolled in remote care programs, spanning diabetes, hypertension, OB use cases, acute care at home, transitions of care, heart failure. And in these programs, over 7,000 clinicians have enrolled patients in these programs. And they didn't start with that kind of scale. They actually started much, much smaller. And iterated with a few clinicians in a specific setting and learned what worked, and then brought that out into other clinics, and then brought that out into other disciplines. And so we started these programs in earnest in 2018. And now since then, it's grown to the point where they have significant scale and patient impact and huge cost savings because of it. But, when they first started, they didn't say, well, let's try this and see what happens and then and evaluate it, right? They said, we want to fundamentally change the way we deliver care across Kaiser to include a virtual hybrid model. And so how are we going to get there? We know that we need data from personal health devices. We know that we need that to be in the clinical workflow. We know that we need use cases that will bear out. So let's try some of these things and iterate along the way. And so, we've been a really strong partner with them, and for the last 5+ years. And the reason we've been able, actually, I guess we're in 24, so over 6 years now, live with that program. And the reason why it's been successful is just because of their willingness to iterate toward an ultimate goal.
Yeah, Drew, that vision and commitment is so critical. I have so many clients that I see want to push into a hybrid model of care, and then it's a little bit of like death by pilot, right? Because if you don't put the commitment towards it, you're just going to run into some of those headwinds that Nick, you talked about around you're not really changing your ways of working. I just want to build off of what you both shared. There's a question in the chat. And it's a very nuanced question, so I want to make sure I give it full credit. But really, the punchline as I read it is, how do you make sure that you're bringing to bear these tech platform clinical process capabilities? You need to build credibility with your healthcare community and practitioners, and to be effective, you need to face the headwind of a bit of a relaxed commitment to clinical care in the real world from time to time. Maybe not everything's connected and perfect. Nick, you talked about some of those ways of working needing to be very strong. So how do you think about managing that tension or addressing some of that tension when you really roll out this hybrid model?
It's a challenge. I mean, right? I mean, if it wasn't a challenge, there'd be these programs across the United States right now. I mean, let's
Right.
I think solving the problem first, you got to address, like, yeah, that is a legit challenge and blocker. There's this fundamental tension, especially in the specialties, right? Especially in
Great call out. Yeah.
endocrinology, et cetera, that those communities have been trained to hear, right? And expect the data to hear. In a home environment, the data is not here, the data is here, right? I don't think there's an easy answer to that, right? I mean, there is a trade-off for sure in fidelity and versus frequency, and cost. I think the other element that is really, really important to consider here too is the regulatory environment, right?
Excellent.
So
Yeah.
if you think about a lot of these devices that folks are used to using clinically, they are cleared for in-hospital use applied by a nurse, right? They are not cleared for someone to be using at home in self-application. And that's a challenge too. A specific example, we at Philips are actually working with a number of healthcare providers in the maternal health space. A huge issue and challenge for women, especially as pregnancies in the United States tend to be trending older. A pregnancy over 35 is considered high risk, right? A lot of pregnancies are over 35 at this point in the country. A lot of those pregnancies basically ultimately end up where in the last trimester, the mother needs to go for a non-fetal stress test. And this is it's an important procedure, right? It's a procedure that could be twice a week that they need to go to the hospital to get, right?
Yeah.
And we're working with a number of partners who are basically trying to virtualize that procedure. What's the biggest barrier? One is, how do you make it simple enough for the mother to apply at home? The second one is, how do you make it cheap enough or streamlined enough such that you can basically use that device, right? Because it's only used for kind of 8 weeks. So to throw it away would be hugely expensive and wasteful. So, you know, you got to make that trade-off of, okay, I'm used to having, in this case, a mother come in every couple of days during the week. By the way, almost no one can do that, right?
Yeah.
Or rich, like, no one can take half a day, twice a day a week for 8 weeks. So the vast majority of these appointments are missed altogether, right? So you get nothing. And these are high-risk pregnancies. So the trade-off now becomes like a change in workflow, right? A change in somewhat less fidelity or a potential of the patient applying the NST device inaccurately, right? So you have to redo it. But the upside is you're getting data where you weren't before, right? So the highest level of clinical data you can possibly get is great, but if you're not getting it, it doesn't matter.
Yeah.
But we have to go through, there are real thresholds and challenges in the regulatory and the reimbursement environment that also have to be addressed, right? And if those aren't addressed either in the development cycle or by explicitly, frankly, avoiding them, right? By staying in the MDDS or in the non-device world, those are all trade-offs you have to make across every step of the process. And I think that really explicitly understanding the trade-offs being made in the process, whether it's with a hospital system or all the way up to the device itself, if you're not making those explicit choices, you're going to be making implicit choices, and that's going to lead to confusion and frustration.
Yeah, Nick, I think the picture you constructed for us of the trade-offs and fidelity, but convenience, which we know is really important for personalized healthcare, and then the risk that you just don't get any data is so compelling. There's another question in the chat, and Drew, I might ping this one over to you, and if you have any thoughts from what Nick shared too, please feel free to add those in as well. When we talk about the challenges and barriers of moving to a hybrid or virtual model, one of the challenges might be digital literacy of just your healthcare providers and making sure that it's not just Nick, you point out the expectant mother at home, which is absolutely fair. They're applying advice, a medical device, very likely, or in all cases here. But you might also have providers that are just unfamiliar with this data or how to really think through that. So Drew, thoughts on digital literacy for healthcare providers and how to potentially mitigate that as you're moving to new models?
Yeah, absolutely. So, so clinicians in general are trained on data, and so I like in their medical school. And so, actually, I think that there might be some evolution that needs to happen in terms of how they understand how this fits into their practice. But we've never had an instance where one of our deployments didn't go anywhere because the doctor literally said, I don't understand what to do with this. But I think that, what the way, like a different way to think about that is that if we talk about getting back to that last question around the standard of care that are there today, a lot of it is based around asking patients a standard set of questions and getting their answers. So that is personal generated data in a different way. Like that is people remembering what the answers are, and their memories are not so good. How are you feeling? Oh, I'm feeling really well today. Have you been sleeping? Pretty well. That's the last day and a half or 2 days, but it might have been the last week. 4 out of 5 nights in a row, you woke up and couldn't fall back asleep for 3 hours and were exhausted the rest of the time and were having trouble walking upstairs, right? But like right now, you're fine. So you're going to tell them you're fine. So like that's an example where data is real objective data is better than the subjective memory of patients. And that subjective memory is part of patient care today. So I feel like there's a big opportunity for objective data to be a part of care to help elevate and escalate the standard of care for everybody. I'll give you a really quick personal example. My grandmother on my dad's side, who unfortunately passed away about a decade ago from complications with COPD. Before that happened, she lived in Newton, Iowa, and so rural, and I remember visiting her in the assisted living facility, and she said, oh, I got this new doctor and he's young, and what does he know? He tells me that I need to lose weight. He tells me I need to walk more. He tells me I need to quit smoking. And I'm like, I mean, grandma, like you do need to do those things. Like that's subjective. She's like, yeah, but he doesn't know me. He doesn't know, he doesn't know what I do. Like I walk, to these things with my friends every day. Like I go out and I volunteer garden in the thing. And but he didn't, to her, he didn't even take the time to like get to know her and understand what was happening, right? Like, and she tried to tell him, but it was not like there was probably only 7 minutes for the visit or something. But I think that that's an example where, she could not be engaged by that by that physician because there wasn't a way for him to engage. Like there wasn't a way for him to get to know her in a way that was meaningful for her. And I think that it's possible that additional data about how she's living her life and what she is doing and trying to do could have been helpful.
Yeah, Drew, gosh, that story really resonates with me, and I think probably just about everyone on the call, I'm sure, has had an experience where a loved one, a friend, just had that misconnection in healthcare that sometimes can have pretty significant impact. And my goodness, I was just in a session with some clients last week, and we were discussing the future of who is an HCP, or who is a healthcare professional in general, right? And we kept thinking about the extended care team and how do you create other connections beyond just the prescriber, so that you can mitigate some of this, 7 minutes in person, but maybe it's a nurse practitioner who's really helping and supporting, but you also need time and connectivity for that too. What you've talked about here, Drew, I think also speaks to just how impactful in the story that you shared, a hybrid care delivery model could have really changed the game. And frankly, without that remotely captured health data, there's just an incomplete picture. And certainly for some patients, there's going to be different sort of data types. So if you could just talk a little bit about more of the benefits that you see for patients and providers when you do have that hybrid care delivery model and you are able to capture remote patient data.
Yeah, absolutely. To extend that story with my grandma, her name was Betty, and she, as I mentioned, had complications with COPD, and she was admitted to the hospital for shortness of breath and a low oxygen saturation, and she was there for a couple of days. And when she was discharged from the hospital, she was discharged with, a slip of paper and some instructions on what to do, and back to the senior living facility where she was. And she passed away less than 24 hours later. And when the nurse came into her room the next morning, they found her slumped over her nightstand reaching for the call button. It was really, really sad. And she couldn't get there in time. And I remember thinking to myself, like, why wouldn't they have just sent home a pulse oximeter so that she could understand what was happening? Like, if she's feeling short of breath, I mean, they told her, if you're feeling these things, you need to let someone know. And she didn't have any objective measures. There wasn't a way for her to know what was happening. And then, so that was in my opinion, an avoidable circumstance that really impacted my family. And contrast that with a program that we're running in Southern California with a health system where they're discharging people who have COPD home from the ICU with a kit of devices, including a pulse oximeter, and the data comes back into the clinical workflow so that the nurses can follow that. And if there's anything concerning, the data is escalated via in-basket or in-basket pools, so they can know that they can reach out to that person, engage them, see if they need to come back in. They can create a video visit if they need to, but they can engage that person in the way that they need to. And I feel like that's the real opportunity here, is to just have more timely interactions and better conversations with patients to help people live longer, healthier lives.
Yeah, Drew, gosh, I think that's the goal of every single person I've ever met in healthcare. It's how do we help people live longer, healthier lives? Speaking of a longer time, it's crazy, but we've only got about 10 minutes left. Just for folks who are with us, encourage you to drop questions if you have them. I want to move to the last question here. And Nick, I'm going to pose it to you first. So as I think about all of this potential, and my gosh, if you've checked out ChatGPT 4.0, it feels like there's a lot of potential with where things could go in healthcare right now. I would love to get your perspective on what are some of the trends in technology, data analytics. How do you really see the future shaping up for personalized healthcare delivery? And I'm going to add to that question. You could wave a magic wand. What's the thing that you'd like to see from the future today?
So maybe I'll start with the last question first, right? I think the magic wand is data interoperability, especially.
Oh, Nick, yes, agreed.
There is a lot of, and we've all had this experience, right? You go to the doctor and you're filling out the same form, or you're answering the same survey in your check-in, right? In your MyChart check-in that you've answered 19 other times for 19 other doctors in the same healthcare system. Like, we're not even talking different healthcare systems, right? There is a real challenge right now of we collect the same data over and over and over again, and you can question whether that data is effective or not, right? And what we do with it. So I think, first of all, like, this concept, not to be too kind of consultancy, right, with the trend words, but we need that data to be liquid and be able to move. It can't be in a silo, right? Epic can't own that data. Cerner can't own that data. Philips or Validic can't own that data. It's got to move around. Otherwise, we can't do what we're talking about doing. I think in terms of specific trends in technology, I think there's a couple that I think are pretty exciting. So first of all, the concept of biomarkers, right? So this idea of embedded in data we might be clinically collecting as a matter of course anyway, right? Whether it's an EKG or SpO2 or something else. Can I use AI to learn something more clinically than I know today by looking at it with kind of traditional methods, which includes, by the way, for the most part, a human eye, right? A doctor's trained eye looking at that data. There's a lot of advancements. Mayo's doing work in that. Philips is doing work in that, right? Tons of companies are really looking at how can I use AI to learn more in the same data we already collect. I think that's a great starting point because it doesn't introduce a new clinical activity. I think the second one, LLMs and GPTs and all of these kind of next gen AIs, super exciting. They have to be clinically validated, right? I mean, anyone who's on LinkedIn and kind of has those voices in your feed, you see something every day about some potentially deadly recommendation an LLM is making when you ask it a question clinically.
Just a little bit deadly though, Nick.
Just a little
bit. A little bit deadly.
So I think to get that next generation of LLMs in healthcare, we have to be cognizant of that, right? These have been trained typically on general information. There is a lot of, I mean, Dr. House was a whole series for 10 seasons built around this concept of like, there are some complex interactions that are not necessarily, they still require the human. And they haven't been trained yet. So I think we need that can be really exciting though, if we can start to get over that, right? And start to make that initial triage interesting and more efficient for the physician so they can really apply their specialties. I think the other one, and for those of you who don't know them, there's a company called Echo, right? So one of the things that I'm super excited about, and Echo is kind of a use case example. How do we take traditional clinical activities, make them digital so we can start to use that data in new and interesting ways? So Echo, I'll give as an example, because what they've done is they took a stethoscope, right? Been around for 150 years. They said, hey, what if we digitized it? Well, now if I'm capturing that digital audio signal, because that's what a stethoscope does, right? It just magnifies an audio signal. Well, now can I take the best cardiologist who can hear what a murmur sounds like, and can I turn that into an algorithm, right? Now all of a sudden you have the capability of the best cardiologist who can hear heart murmurs available to everyone. That is really exciting, right? If you take that kind of same MO and apply it across the healthcare system, now you have amazing compounding effects, right? Where you have the best specialists available virtually, essentially to everyone, right? And including potentially consumers. So those three things, right? Data liquidity, because if we can't move the data around, we can't do anything with it.
Yeah.
Training LLMs to be clinically validated, right? So we don't have these silly LinkedIn posts. Not that the posts are silly, but like the silly recommendations that someone's saying, hey, if I did this, I would have killed my patient.
Yeah.
And how do we create virtual models off of existing clinical practices that we can kind of democratize the best and brightest, right, amongst our clinicians out to the rest of the world, right, through digital tools and applications.
Yeah, Nick, I'm going to be very optimistic. And when do we think we can achieve this future? Like, it'd be amazing if it could be in the next 6 months, but
the last one is first, right? I mean, Echo, I think someone's citing Butterfly, right? Philips, lots of companies are doing the last one already, right? There's a whole exercise though around retraining our clinicians, and Echo's done a great job. Their commercial strategy, they went to the medical schools first, right?
Yeah. Yeah. Those are excellent examples, Nick. Drew, all right. You've got your magic wand.
Yeah.
What are you going to change for the future of health tech? How are you going to help us all, Drew? Please let us know.
Yeah, absolutely. So, man, I'm going to go a little bit different, maybe a little dark. I don't know, but I like if I could wave a magic wand, I would say universal adoption of value-based care with consistent contracts. Because there's moderate adoption of value-based care today. The contracts are wildly different in every instance, and it just makes navigating it extremely challenging for payers, for providers, for large self-insured employers, for vendor partners. And so that would be the thing that I think would really drive the most alignment around some of the topics that we're talking about. And in terms of the technology, Nick, you gave an incredibly comprehensive answer. So I'll add one piece, which is on the digital biomarkers, the opportunity is that, as you said at the beginning, we have more people who need more care, and we have fewer people to deliver the care. So how can we use the technology to help clinical teams understand how to prioritize their resources and know that everybody else is okay? Because right now, it's a bit like an auto shop where the clinical teams are sitting there, and whatever car pulls into the garage is the car that they're going to work on, whether they have a nail in their tire, or they need an oil change, or whatever the case may be, right? But it might be that that oil change is not as important as that nail in the tire because there's a baby in the car, or whatever the case may be. But they don't know. They just work on whatever they work on, right? And so I feel like we need to upskill or not even upskill, but up level how we leverage our clinical skills to be able to focus on the things that are most important, right? How can we use the technology where if a physician is reviewing 200, a radiologist reviewing 200 images, how do we know that the first one is the one that needs to be reviewed first? Like, use AI to help with that, right? If a nurse is going on rounds and they need to go to 30 beds, how do we know that the bed they go to first is the one they need to go to first? If a care manager is making 200 phone calls in a day, how do we know that the first phone call is the one that's the most important, and that the person's not getting off an 8-hour shift to your point earlier?
Yeah, totally.
So
yeah.
Those are the things that I feel like technology and biomarkers can make a really big difference on.
Drew, I don't think you were that negative. I think the future's bright. There's lots of opportunity. We can make an impact. We'll make an impact together. My gosh, I can't believe that we've already gotten to the end of our conversation together. It's been a lot of fun. Thank you, Nick. Thank you, Drew. And goodness gracious, thank you for all the folks who were able to join us for the last hour or so. Personally, I'm incredibly inspired with the future of healthcare and how we can continue to drive virtual care and better data connectivity to improve outcomes. Nick, Drew, any final parting words here?
Thanks for the time and facilitation, Laura.
All right. Well, thank you so much. Everyone have a fantastic day, and take care all.
Thanks, everyone.
Bye.